Good morning, everyone. I'm Yagnapri, and my topic for today is narcolepsy. So, we'll be talking about epidemiology, etiology, pathophysiology, clinical features, diagnostics, and treatment of narcolepsy. Let's take a look at a case. A 17-year-old girl is brought to the physicians of generalized fatigue and during this period, she has had excessive daytime sleepiness. While going to sleep, she sees cartoon characters playing in her room. She wakes up once or twice every night. While awakening, she feels stiff and cannot move for a couple of minutes. She goes to sleep by 9 p.m. every night and wakes up at 7 a.m. She takes 2 to 3 15-minute naps during the day and wakes up feeling refreshed. During the past week, while listening to a friend tell a joke, she had an episode in which her head tilted and jaw dropped for a few seconds. It resolved spontaneously. Vitals are within normal limits, and rest of the physical examination is unremarkable. Now, let's take a look at differential diagnosis for excessive daytime sleepiness. It can be due to insufficient sleep, can be due to medications and substance abuse, can also be due to sleep disorders like obstructive central sleep apnea. In patients with sleep apnea, there's a history of snoring and they have interrupted sleep and they wake up. Another cause is central disorders like narcolepsy and idiopathic hypersomnia. We'll talk about narcolepsy in detail in a minute. Circadian rhythm sleep-wake disorders can also cause excessive daytime sleepiness, especially in patients who do night shifts. And sleep-related movement disorders like restless. We also need to exclude medical disorders like hypothyroidism, hepatic encephalopathy. In patients with hepatic encephalopathy, reversal of sleep-wake cycle is one of the first symptoms. Psychiatric conditions like depression can present with early morning awakening, whereas in patients with anxiety, they usually have interrupted sleep and increased sleep latency. So what exactly is narcolepsy? It's a chronic sleep disorder characterized by overwhelming daytime drowsiness and sudden attacks of sleep. It's seen in about 25 to 50 in 100,000 population. And like some of the other diseases, it is bimodal in distribution, peaking at 15 years and another small peak occurring around 35 years of age. Narcolepsy can be either primary narcolepsy or secondary narcolepsy. Primary narcolepsy. In narcolepsy type 1, there's loss of hypothalamic neurons, which are responsible for secreting hypocretin 1 and 2, also known as orexin. This neurotransmitter is responsible for sleep cycle regulation. Whereas in narcolepsy type 2, there's no change in orexin levels and the cause is unknown, it's idiopathic. Secondary narcolepsy can occur due to cerebral damage due to stroke or tumors, inflammation, and other genetic syndromes. So moving on to pathophysiology, orexin-containing neurons in lateral hypothalamus, they activate the reticular activating system, and which in turn secretes dopamine, norepinephrine, and these inhibit REM sleep and reduce the secretion of acetylcholine. During normal REM sleep, orexin decreases, which in turn reduces RAS activity and promotes atonia. So in REM sleep, we see loss of tone in the muscles. So this is the pathophysiology. Orexin deficiency can lead to cholinergic hyperactivity since orexin is counteracting acetylcholine. So in its deficiency, we see cholinergic hyperactivity, which is responsible for cataplexy, hallucinations, and sleep paralysis, which are commonly seen in narcolepsy, and dopaminergic hypoactivity, which is responsible for excessive daytime sleepiness and automatic behavior. So the typical clinical manifestations of narcolepsy are excessive daytime sleepiness, and it can occur despite a patient having adequate sleep the previous night. And the patient can also have abnormal REM sleep, which we'll talk about in detail in our sleep studies. Another typical presentation of narcolepsy is cataplexy. In cataplexy, there's loss of muscle tone, uh, which lasts only for few seconds. This is similar to the one observed in REM sleep. Patient might typically present with partial cataplexy, where the loss of tone is seen in only a certain group of muscles. And this cataplexy is usually triggered by emotions, strong emotions. So this is a picture depicting cataplexy, where the patient falls down due to loss of muscle tone in the left side of his body. We also see sleep paralysis in patients with narcolepsy minutes after waking up or before falling asleep. And other characteristic findings are sleep hallucinations. Hypnagogic hallucinations are where patient might experience visual or auditory hallucination as they fall asleep, or hypnopompic hallucinations are experienced when the patient is waking up. So how do we diagnose narcolepsy? We need to rule out other causes of excessive daytime sleepiness that we've discussed in the first slide. And we can use a sleep questionnaire called Epworth Sleepiness Scale. And we can recommend a patient to keep a sleep log for about 1 to 2 weeks so we can get an idea about the sleep hygiene, and we can take a look at the stimulant use. One of the most important tests for narcolepsy is multiple sleep latency test. So in sleep study, we give the patient 5 opportunities to nap during the day, and we measure sleep latency, that is the time required to fall asleep. Sleep latency is usually less than 8 minutes in patients with narcolepsy. Another important thing that we take a look at in narcolepsy is sleep onset REM periods. In patients with narcolepsy, REM periods occur within 15 minutes of falling asleep. This is an image showing sleep studies of a normal patient compared to the sleep pattern in narcoleptic patient. In patient with narcolepsy, you see that a patient goes into REM sleep within 15 minutes of falling asleep, and there can be more than 2 sleep onset REM episodes. So sleep latency less than 10 minutes and more than 2 sleep onset REM periods are characteristic of narcolepsy. So there's a diagnostic criteria for narcolepsy. The patient can have usually present with daily periods of excessive daytime sleepiness for about more than 3 months. And in type 1 narcolepsy, the patient will present with more than 1 episode of cataplexy, plus characteristic findings on sleep study or low hypocretin levels in CSF. But since measuring CSF hypocretin levels is usually done. Whereas in type 2 narcolepsy, just findings on sleep study without cataplexy or reduced hypocretin levels. Like I mentioned before, lumbar puncture is not routinely indicated since it's invasive, but if we do, we can find reduced hypocretin or orexin levels in patients with narcolepsy. We can also do MRI brain to rule out secondary causes of narcolepsy like stroke, tumor, and other inflammatory conditions. So while treating a patient with narcolepsy, we need to we want to improve their quality of life. So we want to reduce the daytime sleepiness, and we want to control the cataplexy, nightmares, hallucinations, sleep paralysis. So we want to improve the overall quality of patient's life. We first start with non-pharmacological treatment by optimizing sleep hygiene. We can advise patients not to use screen before going to bed, and we can advise them to take scheduled naps during the day for about 20 minutes. We also ask them to avoid medications like benzodiazepines, alcohol, and opiates, since their effect can carry on to the next day and can cause excessive daytime sleepiness. We also ask them to avoid stimulants like coffee, theophylline, because they can worsen insomnia and causing daytime sleepiness the next morning. Prazosin is a drug which is used for nightmares, but it's avoided in narcolepsy as it can worsen cataplexy. So after non-pharmacological, we move on to medical therapy. Modafinil is one of the common drug used in patients with narcolepsy. It's a non-amphetamine CNS stimulant. And at night, we can advise them to use gamma hydroxybutyric acid or sodium oxybate. It promotes proper sleep. FDA has approved 2 drugs in 2019, which are solriamfetol and pitolisant. Solriamfetol is a selective dopamine and norepinephrine reuptake inhibitor, and these neurotransmitters promote wakefulness. We'll talk about pitolisant in a minute. Dextroamphetamine and methylphenidates are second-line drugs used in narcolepsy. Before we talk about pitolisant, let's take a look at role of histamine in narcolepsy. Histamine is a wake-promoting neurotransmitter present in the cortex and subcortex. It has 2 receptors, H1 and H3. When histamine binds to postsynaptic H1 receptors, it activates regions that regulate sleep-wake stability. But when histamine binds to H3 receptors, which are present in the presynaptic vesicle, it reduces the release of histamine, thus promoting sleepiness. So this drug, pitolisant, which has been approved by FDA recently, binds through H3 receptor in the presynaptic vesicle and acts as an antagonist or inverse agonist, thus increasing the release of histamine, thus promoting sleep-wake cycle regulation. It's the first non-controlled substance for narcolepsy available currently. Thank you. And the other, so I would like to add a word on other REM sleep suppressing drugs like antidepressants, which inhibit reuptake of norepinephrine, serotonin like venlafaxine, and tricyclic antidepressant. But we don't advise these drugs regularly because abrupt withdrawal of these drugs can trigger status cataplecticus. Thank you.
Thank you. Okay.